Thank you, Dennis. Thank you very much, ladies and gentlemen. Thank you for inviting me. This is my first time here to give you some of my experience and my knowledge about the breast ultrasound. So as you know, ultrasound is a breast radiologist's bread and butter. This is where we live. This is what we do, and it's quite crucial to know where to start, what to look at, and I hope I'll be able within this half an hour capture this huge information and give you an idea of what we're looking at. So this is a part of a hospital I'm working at, and I'm coming from Aberdeen, which is the third largest city in Scotland, the coast of the North Sea. Very beautiful. I love it a lot, and I have been brave enough and put some Scotland images into my presentation. Hopefully you can like that as well. So I believe all of you recognize this bridge, because even if you're not Harry Potter fans, this is the bridge where the train goes to Hogwarts, and it's just in the middle of the Scotland, and it's a beautiful place. So it's worth to go and see it. But let's go to the breast. So doing ultrasound of the breast is a lot of indications, and I'm sure you know them all. So first of all, it's definitely dense glands with lumps, which are palpable. Pregnant patients, male breast, young patients. I haven't really mentioned, but that's probably would be silicone implants as well. Ultrasound can be used in screening settings as a screening modality, but also as a symptomatic one. And if we're talking about the symptomatic, most often we are characterizing findings on mammogram. First of all, determining whether the lesion is cyst or a solid mass, and then whether we would think of benign or malignant finding. Sometimes we see things on one view only, on one mammogram. So ultrasound is an excellent tool to confirm whether we can let the lady go, because there's nothing in there, or we should keep her slightly longer and do an assessment on the area. Clinical examination-related findings such as lump, areas which are not included in mammogram, so that would be very medial, close to the breastbone, or very lateral, also axillaris. Nipple discharge is an area which we can assess with ultrasound, and breast swelling. Ultrasound also is used on a follow-up of neoadjuvant chemotherapy ladies, second look ultrasound, of course, and that can be done after mammogram and after MRI, and most definite also guidance of interventional breast procedures. There'll be bigger talk tomorrow, but I'm going to mention this today as well. So talking about ultrasound, we should consider what we're looking at when we're looking at the lesion, and there are certain criteria or features we would be focusing at. Ultrasound quite rarely is used as a solitary modality, so we always would combine this with a mammogram whenever it's possible. And let me just give you an insight of the features we would be looking at. So some of the features we can see and appreciate on mammogram as well, but some of them are very typical only for ultrasound. So one of them is echo pattern, which is comparing echogenicity of the finding to surrounding fat tissue, orientation, shape, margins, of course, echo transmission or posterior features, also blood flow and elasticity. Talking about echo pattern, as I said, we are comparing the echogenicity of the lesion to the surrounding fat tissue, and this can be anechoic. So at the example, you can see that very black lesion, very black compared to the fat tissue, and probably you already all know what exactly it is. Hyperechoic and opposite. It's white, it's whiter than fat, and it's very important to appreciate echogenicity. So we all know that hyperechoic lesions, total majority, are benign. However, we have to keep in mind that things can be different. Isoechoic, same echogenicity as surrounding fat tissue. This was fibroadenoma, very, very nicely seen on mammogram, and targeted ultrasound revealed this isoechoic lesion, which I strongly believe could have been lost if we wouldn't have mammogram. Mixed or heterogeneous lesions, so it contains solid and cystic areas and gives an impression of this very, very heterogeneous appearance. And hypoechoic, probably something we would know the best and we would see the most, which is slightly darker than surrounding fat tissue. Let's move to the next feature, which is orientation, and which is very, very typical and for the ultrasound and can be appreciated in ultrasound only. So when we're talking about the parallel orientation, most of the time we would think of benign finding and the vertical, of course. So you quite a lot see the expression taller than wide, which means that front to back measurements are way bigger than side to side. Shape, so it can be oval or ellipsoid, and in this case we are thinking most likely of benign lesions, of course, but then the shape can be different as well. So, and the more rounder it gets, the more we would think of slightly, we would be worried about that more. So in this case, this very round lesion, if you would know nothing about the lady, you can think it's benign, but that was grade 2 invasive ductal cancer. So quite round, you can apply other features and other criteria and make your decision on the finding. And irregular, which we all know most likely would be typical for malignancy. However, there are findings which can be irregular in shape and still be benign. I'll speak about them later. Talking about margins, they can be very nice, ill-defined and crisp, and you can literally take a pencil and draw the line along them. And they also can be irregular, and you have to look at the way they are irregular if you're describing the lesions. So they can be microlobular. You can see these very, very small lobulations of the lesion. They can be spicular. So if the fibrotic reaction around the tumor increases, you can have and see these little spiculations. And this is just the way the margins can be. Angulated margins could be malignant. In this case, that was a radial scar. And indistinct margins, when you really hardly can take it away from the other tissue, especially if you don't have anything else apart from one image only. Echo transmission or posterior features, it's all associated with ultrasound physics. We had an excellent talk in the morning about that. So in this case, the hypoechoic area in the middle of the dense breast tissue, you see there's no really any enhancement or any other posterior features behind. So absence of features is also a feature. It can be a dorsal acoustic enhancement, which is due to the fluid in the lesion. It could be a cyst, but it could be also a necrosis in a tumor, which gives you an enhancement behind the lesion. Bilateral shadowing is quite widely and rightly recognized as a benign feature, and whenever one of the shadows, bilateral shadows, goes away or is not seen, I would say this is indeterminate lesion and would require further investigation. So this is a very typical malignant lesion, but I've put it just to show you that the shadow can be only from one side, and a central acoustic shadowing behind a tumor due to fibrosis most often, or a very, very high cellularity. Further ultrasound features would include blood flow, and we had a talk on a Doppler, so I'm not going to go into details. I would rather, just remind you that in a clinical settings, we would more work with the central or peripheral blood flow distribution and the number of vessels if we're actually counting them. The resistance and indexes, I think it's more used in research and in a very tense clinical settings. Most of the time, we don't really have time to do it. But that also is a criteria which is used to characterize lesion on ultrasound in the breast. So a couple examples, very nice abnormal lymph node. That was a male with a breast cancer, and this was a node we saw just sitting next to the artery. Central blood flow in the case of cancer, so you can also appreciate other features of this finding, and that that's seen centrally. And that was an intraductal papilloma with quite prominent central and peripheral blood flow. In this case, I would say I don't see any blood supply into this current examination, which is also could be a feature just to characterize the lesion, and that was a fibroadenoma. Elasticity just had a nice talk, and I'm not going to go into any details as well. Just strain elastography makes a static map, so you can appreciate the stiffness of the tissue, where it's hard and where it's soft. And shear wave, we compare the speed and the wave's ability to deform the tissues. So elasticity, when it's appreciated on ultrasound, we can see and really filter the lesions we would go for a biopsy. So we do less biopsies of benign lesions, and in a clinical settings, this is very, very important to make a decision. So this was fibroadenoma. You can see a very patchy way, denser areas along with the softer areas, and this is a strain elastography, and this is the cancer just in the middle, where's the denser red bit. You can see when you compare the imaging on both sides. Cystic lesions or cysts is another area which ultrasound is excellent in. So when you see opacity on a mammogram, most of the time you can't really tell if it doesn't have any typical features, of course, what exactly it is. So ultrasound helps you distinguish whether this is a cyst, whether this is a solid lesion. And cysts can be different as well. So a simple cyst, it has all the features of a benign lesion. So it's anechoic, it's definitely blacker than surrounding fat tissue. It has a sharp, crisp contours. Sometimes you can see ducts which are coming in and out of the cyst. You see dorsal enhancement and you see bilateral shadowing, and you know this is a simple cyst, and you can just let lady go and do nothing. The cysts can be complex. They can contain denser bits. They can be insipated. This cyst, after drainage, it just bled. So there's the blood in the cyst at the moment, and there was nothing done with this lady. It's just to show you that cysts can be complex as well. And complicated cysts, when we see, again, cyst with a denser content, thicker walls, abnormal blood flow. In that case, we're talking about a complicated cyst, and the level of suspicious for malignancy is quite high, so we have to do something more into this case. Always when you see the cystic lesion, especially with a small one, especially very deep located, think of other diagnoses. So there is a thing called satisfaction of search. Don't stop when you see the cyst. Really appreciate all the features, and only when you're really happy to cyst, you can let lady go, because very small ductal cancers, lobular cancers, metastases, or lymphomas, as in this case, can mimic small cystic lesions. Just don't let them go. DCIS is another entity on ultrasound. So we don't characterize microcalcifications on ultrasound. We just don't do them because we can't really appreciate them the way we can on a mammogram. However, DCIS can be seen on ultrasound, and if we're combining both modalities, we can very nicely see mostly as the ductal change. So we can see wider ducts with thick walls. We can see small hyperechogenicities in the duct, which can indicate calcifications. So we can see the area of diffuse textural change containing calcifications. And very, very rare, there is a situation when DCIS can actually be a solid mass. So as I said, always, always appreciate. So if you have a slightest concern that a finding in a breast can actually be associated with a calcium or DCIS, you have a clinical suspicious, just go and do the mammogram, and that will help you hugely to sort out the problem. And as I said, calcifications can't and may not be analyzed on ultrasound because we just don't see them. And this is an example. So all the hypoechoic tissue, slightly hypoechoic, I would say, containing little small dots. This was DCIS, so in this case, this was over 7 centimeters. That was a young lady, 38 years old. And we started with ultrasound and just that didn't felt right, so we did mammogram, and there was loads and loads of calcium, but this is what we saw on ultrasound. So part of the Scotland actually consists of islands, and this is a very popular celebrity in one of the islands, in Shetland Islands. So these are cattle, they're just growing them, and this guy is really friendly and very popular, so just to entertain you. Okay, so keep it in mind, all ultrasound features we're looking at. I just summarized the criteria for benign lesions. So they have to be smooth and well circumscribed. They are whether hyperechoic, whether isoechoic, whether mildly hypoechoic. Sometimes you can see thin echogenic capsule, especially in a case of fibroadenomas. The shape is oval or ellipsoid, and it's most of the time horizontal orientation. They can be lobulations, but they can't be really more than 2, 3, and you don't have to see anything else. In that case, you're saying, yes, I'm happy. This is benign lesion. I'm happy to score it as 2, as per BIRADS, and do nothing, and just let lady go. If any of these criteria is absent, I would go for the worst feature, use the most suspicious feature as denominator and chase it until you're happy that this is benign thing you can let go. Very rich slide, I would say, a lot of benign things, and these are the things we mostly see in a breast when we're talking about the benign breast lesions. You can quickly read them all, I'm not going to read them. It's just to remember that each and every of these bits can represent a benign lesion in a breast. Slightly tricky with the inflammatory lesions, but we have a full range of things to appreciate them. These are criteria for malignant lesion, and on the left side you can see positive predictive value. I'm sure you all know this, but positive predictive value is something that you say malignant feature. If the lesion has it, it has a very high possibility that the lesion really is bad. Now, how they say, if it walks like a dog and talks like a dog, most likely it is a dog. So this is what positive predictive value is. The speculation and a vertical orientation would be the most suspicious features, which would be very, very indicative of malignancy. But you also have to appreciate all the other things. So even if you're looking at the duct extension or microlobulations, most of the time that will be malignant. There are multiple benign lesions which mimic malignancy, and that can be scored as BIRADS 3 for A, for B, and that just means that you're not stopping where you see the lesion. You move forward, you do the biopsy, you do the further investigations, tomosynthesis, MRI, until you get the diagnosis of benignity and can reassure the lady. So abscess, hematoma, radial scar, yes. Post-surgical scars, diabetic mastopathy cause a lot of headache in a clinical settings. Focal fibrosis, adenosis, granular cell tumor, and changes of the nodes which are related to infection or vascular lesions or tuberculosis. Knowing all the features and putting them all together help you to put the lesion under the BIRADS category. And because you know where your lesion is sitting, you know what to do with the lady. So if you're doing ultrasound and you really feel like you're too short, then it's 0 and you're just doing some further things. You're moving on, and whether doing follow-up or further sampling with 3 and 4 and 5 definitely needs to be investigated, and then you just have your features based upon which you are acting, And as I said, you always use the worst feature, the most malignant feature, and work this through, even if it's only one. So hyperechoic lesions, I did said that mostly they are benign, and I'm standing for it. However, about 5% of all biopsy lesions would be hyperechoic, and 0.6% of all the biopsies would come back, of the hyperechoic lesions, would come back as a malignant. So you can see the reason why the lesion is hyperechoic, and the list of benign findings would still be way more, whether this is fat, fibrosis, vascularity, or a lot of cells. But you have to keep in mind also that these things can be malignant and shouldn't let lady go just because you think it most likely is benign. Ultrasound and screening is a very quickly, and I would say rapidly developing thing. So what do we want from screening? We want a tool that is sensitive enough, specific enough, which is cost-effective, safe, and acceptable for the screening population. So when we're finding small cancer, it allows us to treat it at the early stage. It reduces significantly mortality. And most often, nowadays, yet, mammogram is used as a main screening tool. So breast cancer can be represented on a mammogram as 5 main features. It's an opacity, and I'm not characterizing it, I'm just saying it's opacity, it's asymmetry, it's distortion, calcifications, or skin changes. Ultrasound, unfortunately, can't provide you all these features and pick up all of them. Mainly, this is asymmetries. Ultrasound would not be able, because it gives you a very targeted view of the breast rather than general. However, if we combine mammogram and ultrasound, it hugely, hugely increases sensitivity. So the mammograph sensitivity in a dense breast, you see it's quite low. It's 48 to 65%, which is not enough to be a good tool. If we are adding ultrasound, so we get cancer detection 97.3%, which is absolutely amazing. So, but because it's very time consuming and highly operator dependent modality as well, there is some, this might be one of the minuses. Automated breast ultrasound system, which is used more and more, is an excellent tool as well. Again, quite time consuming. However, you have to understand that there's quite a lot of things ultrasound picks up which are not cancers. They are just mimicking cancers, which leads to increased rate of benign biopsies. And this is something we would like to avoid in the screening, but there's definitely a future. Neoadjuvant chemotherapy follow-up, another indication for ultrasound used in breast imaging, always should be used together with a mammogram because, as I said, it gives you, mammogram gives you a general idea of the situation in breast, and ultrasound gives you very local and very specific idea what's going on there. So neoadjuvant chemotherapy is really good because it has changed the cancer management, and there will be talk about that tomorrow, but in very briefly, it does change inoperable cancers to operable cancers, and it reduces, it shrinks the tumor significantly, which is a great thing because ladies can undergo the breast conserving surgery rather than have mastectomy. Second look ultrasound, another feature. So most of the time, second look ultrasound is used after MRI. And MRI we're using quite a lot in a preoperative assessment. So you all know indications. So this is whether lobular cancer or mixed organ cancer. This is multifocal cancer. This is differences in the sizing on the mammogram and ultrasound. Evaluation of the opposite breast, especially in the case of the multifocal cancer, and mammographically occult cancer, we would do MRI as well. So the main aim is picking up other focuses because it can hugely change the management of the disease. So which things should be subjected to the second look ultrasound? So these are findings on MRI which are irregular in shape, irregular and spiculate margin, marked enhancement, very focal, or non-mass-like enhancement. Which lesions we shouldn't really put for second look ultrasound is a very focal benign or benign appearing lesions such as lymph nodes or fat-containing lesions, as well as masses with oval or round shape and very crisp, nice margin on MRI, and also masses with homogeneous internal enhancement. We should recognize them as benign and not subject for second look ultrasound. So detection rate of secondary foci after MRI UC is quite different and also quite high, up to 71%, which is a big. Guidance of interventional breast procedures, ultrasound absolutely definitely would be the leading modality. And there is a lot of interventional breast procedures that can be done, and I will have an honor to give you an induction about that tomorrow. So this is it today. So take-home message is that sonography is a first-line imaging technique to characterize clinically or mammographically detected breast nodules. And when we are doing this, we analyze all the features listed below, which is shape, margins, orientation, posterior features, and echogenicity. Always fully appreciate most suspicious finding, and altogether with a mammogram and a clinical context, it will allow to make the best decision into management. Always, worst feature is the one you should pay attention and work on it. Avoid search of satisfaction. On ultrasound, this is very typical, especially for the beginners. You're finding something and you're so happy about that, that you literally let your attention flow. Avoid that, and always follow BIRADS. And that's another nice view in Cairngorm Mountains. Thank you.